Hello everyone. Today we will be talking about pelvic inflammatory disease, also known as PID or abbreviated PID. Again, as part of these STI, sexually transmitted infection lectures. They're going to be quick, some FYI stuff, but mainly bug and drug as far as what is the main number one treatment. So I'll highlight that as we go through. A little bit of background introduction, maybe repeat from ICM. PID is an acute infection of the upper GU tract, genital tract in women. This can involve any part of or all the uterus, fallopian tubes, ovaries, and then maybe some neighboring pelvic organs. Early diagnosis and treatment are believed to be key, so that is good. And then if it is left long-term, you can have issues with infertility and ectopic pregnancies. So here's a little bit of review, but this is up to 10% of women with untreated gonorrhea and 20% of women with untreated chlamydia infections can go on to develop PID. And that's part of the reason we're talking about it here. This is caused by cervical microorganisms, including chlamydia and gonorrhea. Also, some of the normal microflora, vaginal microflora, including some gram-negative rods, streptococci, general mycoplasms, and Gardnerella vaginalis. So because there is a mix of microorganisms, they have studied multi-broad spectrum antibacterial agents. There's some different classes here. Cost, convenience, and administration, safety, allergy history, drug resistant patterns are all things that are needed to be taken in consideration when prescribing for your PID patients. Anaerobic coverage is warranted in patients if they have a history of recent endometrial instrumentation and women who have severe or complicated PID. And you guys will hopefully remember from other lectures, when you want anaerobic coverage, your first line is going to be metronidazole. So go ahead and add that to the slide if you want the refresher, but anaerobic coverage will be achieved by metronidazole. There are, unfortunately, rising levels of fluoroquinolone resistance, so they no longer recommend that. So historically, some older textbooks and stuff may show that the fluoroquinolones were recommended first line. Please do not study that as first line anymore, and that is because of resistance. Cephalosporins are still good to be used and not as big of an issue with resistance. When I'm talking about resistance, though, as always, please note you're going to have to look at your local resistance patterns. So what part of the state are you in? What part of the country are you in? You guys are going to end up practicing all over the world, maybe. I don't know. I don't know where you guys are going to go. It's kind of exciting. You could go as close as Roma, maybe, and then as far away as Rome. Oh, you like how I did that? Rome, Italy, or Rome, Texas. No. Yeah, Roma to Rome. But yeah, you guys can be anywhere. So please check your local resistant patterns. But definitely no more the fluoroquinolones, and the cephalosporins are still pretty good idea. Indication for hospitalization, this is just FYI, but just basically, if your PID patient comes to you outpatient and it is severe enough, they have these issues, you do need to consider hospitalization for your patient. Like I mentioned before, you typically are going to want to go with a broad spectrum antibiotic. You may want anaerobic coverage. You may want to add that metronidazole. So for inpatient management, this is for your hospitalized patients with severe complicated second generation cephalosporin. So specifically the cefoxitin or cefotetan can be used in combination, in one or the other, in combination with doxycycline. Another option, again, this is for inpatient management, is going to be your clindamycin plus gentamicin. So this would be an instance where the person can't take these for some reason. And then once you're going to take that patient off of the IV therapy, and take them to the oral therapy there. Sorry, I'm boring myself here. Sorry. You're taking them from IV therapy to oral therapy. The doxycycline, 100 milligrams BID, can be used. Then for outpatient, you can go with cephalosporin, ceftriaxone. You do that as a one-time dose, IM dose. That's Rofcephin, by the way, for anyone who's wondering. generic Rocephin, IM one-time dose, plus doxycycline, 100 milligrams, BID, 14 days. And then, like I said, you can add the metronidazole if you are interested in having the anaerobic coverage. Optimal duration isn't completely known, but typically stick around the 14 days. You notice the 14 days here for doxycycline. But for up to 72 hours, the outpatient therapy should be carefully evaluated to make sure that they are improving clinically. Male sex partners of women with PID should be examined and treated if they had sexual contact the previous 60 days. And this will also help decrease the risk of reinfection. Whoa, and that was it. Is that the last slide? Okay, yeah, these are quick presentations. Sorry, they sometimes surprise me. I was yawning for nothing. Okay, so thank you guys for your time and attention. I always appreciate it. And also, as always, please feel free if you have any questions about this presentation, comments, feedback, please email me, all that good stuff. Talk to you guys later. Bye.